Hi, and welcome back to the Gluten Free RN podcast. Today, during episode 56, I'm going to review celiac disease and non-celiac gluten sensitivity for nurses specifically. Stay tuned. Hi, I'm Nadine Griskowiak, the Gluten Free RN. RN, BSN, CEN. I have been a nurse, an RN, a registered nurse, for 26 years. That's a long time. And for many of those years, 16 years to be exact, I worked in the emergency departments around the state of Oregon. So I did emergency, trauma, critical care. That was my area of expertise. Now, for the last 11 years, my area of expertise has been celiac disease and non-celiac gluten sensitivity. I myself found out when I had multisystem organ failure, a little too late, that I actually have celiac disease and also dermatitis herpetiformis. As a nurse, I had no idea what that meant. I had no idea what those words actually even were. They weren't part of my nursing dictionary. They weren't words that I was familiar with. While I was striving to diagnose what was killing me, I found out a lot about celiac disease and non-celiac gluten sensitivity. So I'd like to review some of those points for you today, especially if you're a nurse or work in the medical field. This information will come in handy, and I've included a handout of celiac disease and non-celiac gluten sensitivity for nurses for your reference. Ever since I started the Gluten Free RN and Celiac Nurse Consulting, practitioners from all over the country have contacted me, and these have been RDs, nurses, MDs, naturopaths, all kinds of people that are interested in what I do and the information that I have. I am an expert in celiac disease and non-celiac gluten sensitivity. And my problem is that as soon as I learn something, research a topic, or integrate a fact or truth into my practice, I somewhat assume that everybody else knows that information, and I'm the one that's trying to catch up. But what I've found over the years, over the last 11 years actually, is that while I may know this information, the vast majority of practitioners do not. So I have to be very careful about, number one, what I say, and also make sure that everything is researched as much as possible, and also anecdotal evidence in this field in particular is very important and quite valuable. And I can explain that, why anecdotal evidence for celiac disease and non-celiac gluten sensitivity is so valuable to our practices. It's valuable because celiac disease is different for every person I've ever seen. It presents differently. The signs and symptoms are different. The treatment plan is typically varied depending on where a person is in healing from celiac disease and non-celiac gluten sensitivity. And for me, as an emergency room nurse, and that's my background, I find this fascinating because no two people are exactly alike. We know that. But especially in celiac disease and non-celiac gluten sensitivity, there are so many variables. It's incredible. And so my brain loves that. But I also know that there's a lot of people that are cut and dry. They like black and white. They like everything to be packaged nicely. Celiac disease and non-celiac gluten sensitivity is chaotic. It's messy. And what I like to do as a nurse is to make sense out of the chaos. I like to organize the chaos. So today we're going to organize it in 20 key points, and you can follow along with me if you've printed off the handout that I've included or the recommended lab sheet that I've included. All very important information, not just for nurses, but for everybody in general. So celiac disease and non-celiac gluten sensitivity for nurses. Let's begin. Number 1, celiac disease is a genetic, autoimmune, chronic, and frequently misdiagnosed or undiagnosed in the United States, and what we're finding is worldwide. Even in the countries that have universal health care, celiac disease is not typically the first thing that people think of or practitioners think of. It really does need to be in the differential diagnosis for practitioners, doctors, MDs, NDs, NPs, PAs, anytime they come across a patient that especially has confusing symptoms that don't fit in neatly to any box. And even if patients have symptoms that fit neatly within a box, they really do need to be reevaluated if with treatment those symptoms don't get better or if more and more symptoms start to pile up. Nurses are in a unique position to recognize celiac disease because we really talk to the patients. We are constantly assessing patients and constantly reevaluating signs and symptoms and how our patients are healing. Are they getting better? So we are truly in a unique position for suggesting that patients get testing for celiac disease, for recommending testing that does get done and gets done appropriately, and then evaluating and reevaluating our patients to make sure that they're getting better, both on a gluten-free diet or a paleo-type diet, to make sure that we're on the right plan. Celiac disease is genetic, and the current diagnosis of celiac disease is a patient must be an HLA-DQ2 and or DQ8 gene carrier and have documented villus atrophy. I talk about in my book why it is difficult, if not impossible, for the vast majority of the people to get that diagnosis. It is very difficult to get a referral to a gastroenterologist. It is difficult to have a biopsy taken correctly. And the other component is neurologists don't actually know about celiac disease for the most part. And celiac disease is primarily a neurological disorder. So anybody with migraine headaches, seizure disorders, numbness or tingling, neuropathy, any neurological symptom, gastroparesis even, or constipation. Constipation tends to be more of a neurological disorder than a lack of fiber and water. So if you begin to look at it from that viewpoint, you will start to see that constipation is really a neurological disorder and not a lack of fiber and water. And hopefully at that point, people will get tested appropriately for celiac disease and non-celiac gluten sensitivity. Testing does involve a genetic test, a celiac antibody test, and an intestinal biopsy, if you could get one. Because many people do not have access to healthcare, we do live in the United States, and even if they have health insurance, they may not have access to healthcare providers or healthcare providers that know about celiac disease. In which case, we really need to advocate for our patients and make sure that they can at least get the baseline tests. And if they truly cannot get testing, we need to be able to support them in going on a gluten-free diet. That is a clinical trial, and it is preventative for so many other healthcare issues. If a person tests positive for celiac disease, they must understand that it is chronic. It never goes away, and they must be on at least 100% gluten-free diet for life. Many people find out that they also cannot eat dairy or drink dairy on a gluten-free diet. I will do a whole topic on the dairy issue with celiac disease coming up. But most people find out that they cannot do dairy on a gluten-free diet. Further, things like soy and corn, and there might be other food allergies that pop up. Once the intestines are healed, and it does take 6 months to a year on a gluten-free diet to completely regenerate the villi in the intestines in the absence of gluten, and that is the key point. There can be zero gluten exposure for those intestinal villi to heal. There are over 300 signs and symptoms of celiac disease, and that list is growing every day. There's a book called Recognizing Celiac Disease by Cleo Libinati, and she's a nurse. You can reference that book. It was actually printed in 2006. It was one of the original books that I had gotten in my gluten-free library, and it's an excellent resource. If you're looking for further data from that same source, Cleo Limonati and her son, John Limonati, have a website called glutenfreeworks.com. And if you really want to do any research on any topic and the correlation with celiac disease, just go to PubMed and put in whatever topic, whatever disease, whatever symptoms you're looking at, and put in celiac disease after it. Make sure that you do spell celiac disease, CELIAC, but also COELIAC. Interestingly enough, you will get different research articles. That's one of my favorite ways to get information about celiac disease and a specific disease and the association. Roughly 94% of the people that have celiac disease are undiagnosed. Now, we'll never know that true number at this point. We don't know the true prevalence of celiac disease. Just about 10 years ago, the prevalence of celiac disease was thought to be really rare. It was thought to be somewhere in the range of 1 in 5,000 to 1 in 10,000 people had celiac disease. We know that's no longer true. Over the last 10 years, that rate has come down from 1 in 5 to 10,000 to 1 in 2,500, then it was 1 in 1,000, then it was 1 in 750, 1 in 500, 1 in 250, 1 in 133, and it currently sits at 1 in 100. Now, you can see the direction that that's going in, and it's not going to stop at 1 in 100. So we need to be very vigilant about finding people early with celiac disease because this has very significant health ramifications if we're not finding these people with celiac disease early. Currently, the estimate for celiac disease is 3% of the population in the United States, and that is directly from Dr. Fasano, who was speaking at the International Celiac Disease Symposium in India in September of 2017. Now, that's an increase from 1% of the population, which had been stated for many years. Celiac disease can develop at any age, any ethnicity, equally men and women, with any symptom or no symptom. That sounds really confusing, doesn't it? Now, as a nurse, from the emergency department standpoint, I think this is fascinating. But many of you, like I said, like black and white. What is it? Could it really be anybody? Why does everybody need to be tested? The reality is that nobody really had been tested for 70 to 80 years in this country, in the United States. And I know in other countries, it's still the case that people are not getting tested and not getting tested appropriately. So we really do need to do a mass screening. And if you're in a position to institute a mass screening, either in your practice or in your city, wherever you are, please take the opportunity to mass screen people as much as possible. You will find people, and don't be surprised when you do. Some of the most common presenting signs and symptoms would be stunted growth or failure to thrive. And again, that can be at any age. But typically in that case, we want to look at younger children that are not growing or falling off the growth chart, or adults that really did not reach their predetermined height. And a lot of people will say, oh, my entire family is short. We're all short. It's genetic. Well, guess what? So is celiac disease. And that entire family that is short needs to be tested for celiac disease. Chronic anemia and fatigue. Now, the funny thing is, and it's really not funny, but because I have red hair, for years, especially when I was a kid, the doctors would say I had anemia because I was a redhead. Scientifically, that doesn't make any sense, but that's what I was told. We also were told that redheads would typically be more likely to have autoimmune diseases. Interestingly enough, I had 7 before I went on a gluten-free diet and was diagnosed with celiac disease. I don't really have autoimmune issues anymore. A little bit, but overall, my ANA is negative, where previously it had been positive. So just by changing my diet, my autoimmune issues have resolved. Muscle and joint pain. Many of our patients are in pain, whether it's muscle, joint pain, arthritis, whatever you want to call it. Any itis is going to be a potential indicator that celiac disease or gluten is the cause. keeping in mind that gluten and dairy and sugar are all pro-inflammatory. Migraines, seizure disorders, white matter lesions, neuropathy, ataxia, which of course we all know is people that cannot walk straight. They have issues with proprioception. They may walk into walls. They may just be clumsy. These are all neurological issues associated with celiac disease. And even though people are diagnosed with MS or ALS or Parkinson's, it would be a great idea if they were reevaluated and looked at for celiac disease. The best test, the one that actually includes the correct testing for celiac disease, would be the Cyrex Array 3 test. It's from Cyrex Labs, and it tests for the tissue transglutaminase, or TTG 2, 3, and 6. 2 is a general anti-tissue transglutaminase. TTG3 is the one specific for skin, and anti-tissue transglutaminase 6 is specific for the neurological system. So the Cyrex lab tests for all of those, where the general test, the celiac panel test that most labs run, only tests for the anti-tissue transglutaminase 2. This is one reason that many people get missed, is because we're not testing for all of those anti-tissue transglutaminase components of the antibody tests. Abdominal pain, gas, bloating. So anybody that's taking Gas-X or Rolaids or Pepcid or any of the H2 blockers or PPIs, those people should all be tested for celiac disease, because a lot of the people that I consult with had been taking those for years. And we all know that those have their own risks and side effects that are not always very good for our patients. So anybody that complains of generalized abdominal pain, interestingly enough, we had a discharge paper through all of the emergency departments that I ever worked at that said, abdominal pain of unknown etiology. Well, I can assure you, we never tested for celiac disease in the emergency department. So perhaps all of those poor patients that we did see in the emergency department were potentially celiac. A good thing to keep in mind. Skin rashes and dermatitis herpetiformis, which dermatitis herpetiformis, even though it sounds like a virus, is not a virus. It's actually IgA deposits underneath the skin that erupt and cause these very painful, very itchy lesions on people's skins. And those lesions can be on the scalp, on the face, on the chest, on the back, elbows, on the buttocks. They can be on the legs. And frequently those rashes get misdiagnosed as many different things. Eczema, contact dermatitis, dyshydrotic eczema, shingles, and all different types of things. But the reality is that if your skin looks like that, if your skin has a lesion, there's a good chance that your intestines look like that too. Ooh, that's not a good thing. So we really need to start looking at skin in a different way. Every dermatologist I'd ever seen from the time I was a child completely missed my dermatitis herpetiformis. Even though I always presented with the tiny blisters between my fingers, and my skin would be cracked on my hands, and I would typically be given a bar of Dove soap, told to wash my hands and put some special lotion on my hands with white gloves every night, white cotton gloves. Well, guess what? That never worked because I never changed my diet. So we do have to look for the underlying cause for many of the signs or symptoms that we're seeing our patients exhibit. Diarrhea and or constipation. The typical presentation or the classical presentation of celiac disease had always been childhood, abdominal bloating, failure to thrive, and diarrhea. So even in this age, even now in 2018, some doctors still think that is the presenting picture of celiac disease. We know that's no longer the case. People present with diarrhea and or constipation, or primarily constipation. They may be overweight. They may be tall. I'm not particularly short. I'm 5'9"3/4", but maybe I should have been 6'2". I guess I'll just never know. But be aware that celiac disease can present in anybody. And I have a high index of suspicion for the vast majority of the population, mostly because no one has effectively been tested for over 80 years. As a citizen of the United States, I would love to see every person that is homeless, has an addiction issue, has a mental health issue, or is developmentally delayed to be tested for celiac disease. If you're in a position to do that study, please, I will more than happily help you put that study together. All of those populations are very vulnerable. They're very underserved. If celiac disease is the underlying issue for a lot of our social ills, I really implore you to make it a priority in your practice, wherever you practice, to look at those patients differently. I do. And that includes any mental health disorders such as schizophrenia, bipolar, anxiety, depression, all types of things, because it's the gut-brain connection. And there is powerful evidence that the microbiome from our intestines actually influences our brain and how we think and how we function in society. Also, any learning disabilities such as autism, ADHD, dyslexia, ODD, which is oppositional defiance disorder. So anybody that's irritable or cranky or can't focus, those people need to be evaluated for celiac disease proper also. And also keep in mind that a lot of these people may not have celiac disease proper, which would be the HLA-DQ2 and or DQ8 gene carriers with a biopsy-proven villus atrophy. But these people still need to be clinically worked up completely to make sure we're not missing anything. And also any thyroid disorder. For some reason, our thyroid gland has a bullseye for that gluten protein. And the gluten protein will wreak havoc on thyroid glands, without a doubt. In the United States, it takes on average of 9 to 15 years to get a diagnosis of celiac disease. That's abysmal. That's not funny. That's actually could be considered negligent and malpractice on many counts. So I would love it if every practitioner, every nurse kept celiac disease in the forefront and actually advocated for your patients and making sure that they are getting tested appropriately. And not just once, but every year, especially if they're a type 1 diabetic, if they have any autoimmune issues such as autoimmune thyroiditis, lupus, Sjogren's, MS, ALS, Parkinson's. So those people need to be tested every year because they can seroconvert or they can have enough villus atrophy to actually have celiac disease at some point in their life. I will reiterate again that celiac disease is primarily neurological. So migraine headaches, seizure disorders, numbness or tingling, facial tics, tremors, those can all be signs or symptoms of celiac disease. As nurses, we can also advocate that our patients get baseline lab tests for things like B6, B12, a CBC, a chem panel, a vitamin D3 level, magnesium RBCs. There is a difference between serum magnesium and magnesium RBCs, zinc, and iodine. It's very important to have a baseline for most, if not all of those, and maybe a few more depending on your patient. And then being able to evaluate once that patient starts eating correctly and maybe supplementing with some multivitamins or very specific targeted vitamins and minerals to make sure that they are in fact absorbing them. Because we know a lot of people take vitamin D supplementation or iron tablets, but they don't actually absorb them. There are no changes in their lab work, or their lab work actually gets worse. So we need to make sure that we can get a baseline and then reevaluate if our patients are absorbing those nutrients appropriately. Celiac disease that is undiagnosed and also non-celiac gluten sensitivity that is undiagnosed has a huge impact on fetal development and maternal health. There is an 800 to 900% increase in miscarriage in undiagnosed parents. and that's men and women. So if the mom has celiac disease that's undiagnosed, she's going to have a hard time maintaining a pregnancy or carrying that pregnancy to term. As practitioners, I hope you're all aware that as a country, the United States is not doing a good job for maternal health and fetal outcome. There are many more premature births than there were even 10 years ago. Please be aware of that. So we have to look for the underlying cause of that. It's typically going to be food and environmental issues. Increased risk of stillbirth, premature birth, neural defects such as spina bifida. So if we can prevent those things from happening, ideally that's our job as a nurse or as nurses to identify these people, treat them appropriately, make recommendations, work with other healthcare providers to make sure that our patients have the best healthcare that we can provide with the resources that are available. There is a risk of delayed puberty, hormonal disruptions for males and females. This is a big issue for our teenagers. If they have delayed puberty or are not developing appropriately, that has an impact on their later lives and their ability to potentially conceive or carry a pregnancy to term. Ideally, we're going to recognize women before they get pregnant that they are in fact celiac disease. We will treat them with a gluten-free diet and work with other practitioners to make sure that their health is optimized before they get pregnant. Gluten is in medications, in personal care products, and in many food items. It absolutely matters what you put on your skin. Wheat germ oil will penetrate the skin, and it's not just the gluten. For many years, I have debated whether that wheat germ oil or gluten can get through your skin and get to your intestines and cause damage, unless you were eating it. Well, that is patently false, and I will debate that with the highest level of dermatologist anywhere. Our skin is our largest organ. It does absorb things that we put on it. And if you're exposed to gluten on your skin or hydrolyzed wheat protein or any type of wheat derivative, especially if you have dermatitis herpetiformis or any open lesions, your skin, of course, is going to absorb that protein. And it does matter if gluten is in your medications. So if you're a nurse in a hospital and your patient says, I'm celiac and I cannot have any medications with gluten in them, it is your job to make sure that that patient has access to safe medications for themselves. So work with the pharmacist, work with all of the healthcare team to make sure that your patient is safe and doesn't get contaminated in the hospital with gluten. Because really these people are vulnerable. They are relying on your expertise as a nurse and your professionalism to make sure that they do not get gluten in anything, in any form, whether it's their medication or their food, their hospital food as they're trying to heal. So as patient advocates, it's extremely important that we are aware of celiac disease and aware of the fact that even a breadcrumb or a dusting of flour or that binder in certain pills, if it's made from gluten, will cause a reaction in our patients. The antibody tests for celiac disease are 70% false negative nationwide. I am not even sure why we do them still, but they are 70% false negative. There's a number of reasons for that. What we're learning is that more and more people are turning up seronegative, but in fact, they have villus atrophy. So it is very important that we reevaluate all patients that we suspect of having celiac disease, despite them having a negative blood test. It doesn't end there for these people. It is very important that we reevaluate, retest, maybe send them for an upper endoscopy. And the standard for the upper endoscopy for taking biopsies for celiac disease is 6 to 15 biopsy samples from different areas of the duodenum and hopefully the jejunum too, because the damage can be patchy. And even if the patient just shows with inflammation in their GI tract, you should have a high index of suspicion for villus atrophy. And there are 4 stages of that. March 1 is the microvilli are destroyed. Marsh 2 and Marsh 3, the villi start to bend over, fold over, blunt, or atrophy. It starts to look like Berber carpeting. And Marsh 4 is when all of those villi are destroyed or flattened. That damage can be patchy, and it can be in different parts of the intestine. So we need to be advocates for our patient again and make sure that our gastroenterologist or the practitioner is actually taking those samples appropriately, and that those samples are getting read by somebody knowledgeable, either a histologist or a pathologist that is schooled in recognizing the damage that occurs. Even that Marsh 1 damage is extremely important to recognize before further damage occurs, because we really are talking about organ damage here. We're talking about small intestinal organ damage. And if you think that the entire body isn't affected by that intestinal organ damage, well, we need to talk further, because then it becomes an entire body system issue, which is why so many patients show up with many different symptoms. Test all patients diagnosed with any autoimmune disease, especially type 1 diabetes, lupus, Hashimoto's thyroiditis, Sjogren's, MS, ALS, and the list goes on and on and on as we're adding more and more autoimmune diseases to this list. It's interesting to note that every type 1 diabetic is a gene carrier for HLA-DQ2 and or DQ8. If you didn't know that, that's very primary information for you to understand, because these people, even when they're not children anymore, are still susceptible to developing celiac disease at any age. 30 to 50% of the population actually carry these genes, the DQ2 and or DQ8. So it is imperative that a lot of our patients get this gene test to find out who, in fact, is at highest risk for developing celiac disease. Make sure you get tested. You, your family, and your friends. Advocate for people to get tested effectively and correctly. And if you have a doctor or a nurse practitioner that you work with, please suggest that they get tested also. More and more doctors that I'm working with are finding out that they are celiac. So their attitude is changing, and their perception of what celiac disease is changing as they find out that they themselves have celiac disease or a member of their family has it. Once a person is diagnosed with celiac disease or non-celiac gluten sensitivity, the entire family must be tested as soon as possible and tested every year. Once a test is positive, you're done with your testing, you're in the group, you belong to the celiac disease community. But a negative test does not rule you out. If a child is diagnosed before their epiphyseal plates are sealed, their growth will typically resume on a gluten-free diet, which means they'll grow to their predetermined height, which is a great idea. I love it when kids grow. You can practically watch them grow. It's a beautiful thing. And another thing I'd like to mention is that I don't care how old people are. I want them tested for celiac disease. I had a lovely 99-year-old gentleman say to me, if this diet will make me feel better, I'm going to do it. Oh, I love him. I miss him a lot. He did die, which is okay. He was 99 when he passed away, but his enthusiasm and his quest for quality of life was insatiable. It didn't matter how old he was. He wanted to feel better. So please keep it in mind that a lot of our patients are searching themselves for ways to feel better. And it doesn't matter how old they are. A lot of people will change their diet if given the option and told that they have an opportunity to feel better. Their joints won't hurt. Their muscles won't hurt. They'll sleep better. They'll be able to maybe not take so much medication and have a higher quality of life, which is what this is all about. This has been episode 56 of the Gluten Free RN podcast. I hope you have found that these 20 points from the Gluten Free RN have been useful in your practice. Please print them off, spread them around, give this handout to other nurses that you know, or have them listen to this podcast. And if you are listening to this podcast and you are getting great information, please leave a rating and a review on iTunes or Stitcher, wherever you hear the Gluten Free RN podcast. At this point, I'd like to thank Tim Hallowell and the whole podcasting group for making this podcast available to people worldwide. And also a huge shout out to the Pulse Media Network, a group of nurses that are also podcasters and healthcare advocates. This has been episode 56 of the Gluten Free RN podcast. Thank you very much for joining me, Nadine Griskowiak, the Gluten Free RN. And always remember that nurses are in a unique position to recognize celiac disease and non-celiac gluten sensitivity. And we really do talk to patients much more than almost any other practitioner. Use that access to your patients to evaluate them for celiac disease, and don't forget to get you, yourself, and your friends tested. Don't forget to get you, your family, and your friends tested for celiac disease today. Thank you very much for joining me, Nadine Griskowiak, the Gluten Free RN, signing out of episode 56. Thank you for listening, and have a good week. Bye.